Hello everyone, my name is Brittany Van Arsdale, and this is a presentation of my DMP project titled Comparison of Chronic Wound Treatments at One Outpatient Clinic. The DMP committee included my chair, Dr. Teresa Gallicatos, a community person, Ana Alicia Fall, and the second reader, Dr. Lisa Struer. A little bit about myself. I obtained my Bachelor's of Science in Nursing from California State University, Chico, in Chico, California, and I am pursuing my DNP from Maryville University in St. Louis, Missouri. I am a certified wound ostomy and continence nurse, or CWOCN, and I am currently the wound ostomy department supervisor at my facility. An introduction to my topic. Chronic wounds have been called a silent epidemic in healthcare. They are estimated to affect 6.5 million patients in the U.S. every year. And wound care is not only costly to the patient, the healthcare system, and the community, but these wounds are also difficult to heal. They require lengthy treatments, time and effort on the part of the patient and the family, costly dressings, and many visits to providers for the wound care and even home wound care at times. And there's also the possible complications associated with these wounds, which can be quite severe, usually related to infection, and these complications can include sepsis, hospitalizations, and even amputations or death. There are no current established guidelines for wound care. There are no across the board ways that are best practice to treat chronic wounds. And so part of this study is to give more evidence in order to proceed to that point where we can start developing those guidelines for providers. The purpose and aims of my project. The purpose was to evaluate skin substitutes on diabetic and venous ulcers. Skin substitutes are one of the newest products on the market and one of the most numerous. And diabetic and venous ulcers are two of the most common types of chronic wounds. The aims were to improve healing times of treatment-resistant wounds and to provide evidence-based treatment modalities and guidelines. So we want to heal these wounds faster in order to prevent more of these complications from happening and to help develop those guidelines that are so greatly needed in the area. And ultimately, all of this is to improve outcomes for our patients. So you can see in the diagram here, there is a photo of a skin graft, and all of these components can be things that go into these skin grafts. And then right here you see the application to a leg wound. And then here, this is the product which needs to stay with close adherence to the wound bed. And so there is a mesh product placed over it, usually a silicone mesh, and then usually secured with something like steri-strips. And that's left in place for about a week. And then the patient will come back to the clinic every week for evaluation. The wound will be cleaned and usually debrided, and then another application of the product will occur. And so this occurs weekly until what we hope ultimately occurs is that we get total skin tissue regeneration and the wound heals. So wouldn't you all like to know how long it took this wound here to heal and what product was used? That brings us to my DMP question. Is the use of skin substitute products beneficial in the treatment of chronic diabetic and venous ulcers? The theoretical model used for my project was the Ottawa Model of Research Use. The model says that a practice change is supported by evidence and that it also considers individuals and the environment involved. And the last step is that the practice change should be reevaluated, and this is based on patient, provider, and system outcomes. And this is the portion of this process that my project comes in, is reevaluating the outcome of the practice change. And so here on the diagram you can see all of these components that go into it, and that is people, and there's technology, and then there's the process itself, and this all is part of the learning system, and each portion depends on the previous and the next, and they all integrate with each other. So a review of the literature showed three major themes when reviewing skin substitutes. The first is that skin substitutes were shown to decrease complications in chronic wounds. So these products were shown to facilitate faster healing and also to decrease scar tissue. So these products generated faster and better quality granulation tissue that was more sustainable and helped progress the wounds to healing completely. And later on actually showed that they decreased deformities when compared with other treatment modalities. So in the areas that these wounds healed, especially when they were over bony prominences or high movement areas, it actually showed that the tissue that formed and the fact that there was less scar tissue led to these patients having better mobility and less problems in the area later on. The second theme that arose was the versatility and availability. So these products work independently, but they also work in combination with other therapies. So this allows for adjustment based on the wound and the patient's lifestyle as well. Sometimes wounds are heavily draining and they need a very absorbent dressing. So you can place an absorbent dressing over these products. Sometimes an antimicrobial is needed, and these products have been, there's research been done on antimicrobials in these products themselves or in the secondary dressing. And there's also, you can add moisture to the secondary dressing if needed, if a patient needs a longer wear time or a shorter wear time. So one of the benefits to these products found was that you can really combine them with a lot of other things and get exactly what you need for each patient. They also can be an alternative to expensive dressings. Although these products are generally expensive themselves, there are parts of the world where studies have been done on very inexpensive versions where skin substitutes are made from readily available fish skin, and then they can be used either as a temporary dressing just in order to get the patient to a facility where they can receive higher level wound care, or they can actually use these sometimes, and they have shown that that they can progress the wound to healing even with these kind of more primitive versions of these products. The third theme was that these products offer the potential for a new gold standard in wound care. So an alternative to an autograft, which up until this point has been considered the gold standard in wound care for very large or very difficult to heal wounds. An autograft requires a major surgery. It requires creation of a donor site, where the skin graft is harvested, and then the skin graft is meshed and placed over the original wound. And then you have a donor site, and the patient then needs to be treated and monitored for healing of the donor site, as well as the autograft site, or the site that was grafted. So these products, these skin substitute products, have been shown to be very beneficial when used with autograft in the research. However, research has also shown that they may start replacing autografts, and in some cases have, because not all patients want to or are candidates for a major surgery, and that if the same outcome can be achieved without having to do an autograft surgery, then that is a very appealing option. So methods and design. The design of my QI project was that I used a retrospective chart review to evaluate the effectiveness of a practice change. So this practice change was evaluated for the outcome and healing times compared with the standard care, and approval was obtained from Maryville IRB. The sample and data collection. The sample ended up being 111 EMRs, which included 78 patients treated with skin substitutes and 33 treated with standard care. The inclusion criteria was patients who were diagnosed with venous and diabetic ulcers during the year 2021 to 2023 in the wound clinic. And the data collected included the wound type, the type of treatment, if the wound healed, the healing time, and then any pertinent notes. So all data was collected on the data collection sheet, and all of the HIPAA identifiers were removed before the data was prepared for analysis. And here is a photo of the data collection sheet that I created, and all of the boxes there that were recorded, and the MR number there were new MR numbers assigned once the data was collected, and so then they were anonymous, and no patient identifying data remained on the data sheet. The data analysis included the Shapiro-Wilk test for normality, which showed that the data was normally distributed. There was then a power analysis done, which evaluates for significance, and this showed that there was a strong probability of significance if a difference was found. And lastly, the independent samples t-test was run. And so here are the results. The Shapiro-Wilk test showed no violation of assumption. You can see here that the p-values obtained were 0.94 and 0.353. And so this shows us that because the p-values were greater than 0.05, there was no significant deviation from normality. So this tells us that the data is likely normally distributed. So we fail to reject the null hypothesis, and it tells us that the data is most likely normal. And then for the power analysis, there is a strong probability of significance because the power was found to be 1, and so that tells us that there is a significance, very probable if a difference is actually found. And then that brings us to the independent samples t-test, And you can see that the result here, the resulting p-value, was less than 0.001, which is less than the established significance level for p, which was 0.05. So this tells us that the null hypothesis is rejected because there is a statistically significant difference between the two groups. And this difference is unlikely to simply be due to random chance. And here is a graph showing the data. So you can see on the y-axis, there is healing time in weeks. And here on the x-axis, it shows the standard care group and the skin substitute group. So we do have a few outliers here, but overall the skin substitute group's healing times are significantly lower than the healing times for the standard care group. So the interpretation of results, the skin substitute treatments did heal the venous and diabetic wounds much faster than the standard treatment, and this was found to be statistically significant. A discussion of limitations of the study. There was a relatively small sample size of 111 EMRs. This study was conducted at a small rural clinic. The study, however, the sample size was adequate enough to make the results reliable for the test run, and therefore there is generalizability of the study. And so the statistical significance found allows us to extrapolate to larger populations and other areas of wound care. So there is continued research needed for skin substitutes. Products on various wound etiologies should be examined and discussed to further direct care. There should be more research done looking at specific products and their treatment in specific wound types, which is lacking in the research and will require quite a few more studies in order to be able to establish proof for reimbursement and also for guidelines for providers moving forward and knowing which clinical situations will be best treated with which products. The sustainability of this project was very good. There were low costs and a very minimal burden to the facility where it was conducted. So the implications of this study, the skin substitute practice guidelines, are something that this gets us one step closer to developing. These skin substitute products are the latest innovation and they are changing wound care. They have become very popular and are showing great promise in the research. And this study is one more step showing that they do truly improve objectively the healing time in chronic wounds. And so policy changes are also something that we are getting closer to. With more research, we can show that these products are effective and we can generate more availability for patients so that all insurances and whatever wound type, that every patient will have the same access. Currently, it's dependent on insurance. These products are too expensive generally for patients or facilities to cover the cost. So more research will allow us to lower the cost of these products and standardize reimbursement so that patients can all have that same access and good outcomes that are associated with these products. Quality and safety, more research is needed on these products as far as longevity studies. There are some thoughts of possible malignancy later on in life mentioned in research. No studies have actually proven this, and so more research will be needed as these patients move further along in their life that have been treated with these products to see if there's actually any truth to that concern. So in conclusion, skin substitute products do heal chronic wounds at a statistically significant level compared to standard care. And more research is needed to expand the use and to improve access and outcomes for patients. And please feel free to contact me with any comments or questions. Here are my references. Thank you for listening.